Welcome to Doctors on Call. I'm Jenna Miller. 1 in every 4 deaths in the United States is caused by heart disease. Coronary heart disease is the most common type. You may experience chest pain, lightheadedness, shortness of breath, or nausea as a precursor to a heart attack. While heart disease is the #1 health threat in the world, the good news is most heart diseases can be prevented with healthy lifestyle choices. How do you know if you're at risk? We'll find out more today on Doctors on Call as we discuss heart disease with our guest, Dr. David Battin.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Salina Regional Hospital, experts, neighbors, friends.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.
Dr. David Battin received his medical degree from the University of Kansas Medical School. He completed his residency at the University of Kansas Medical Center in Wichita and his fellowship at the University of Tennessee Health and Science Center and William Beaumont Hospital. Dr. Battin is board certified with the American Board of Internal Medicine, Cardiovascular Disease, Nuclear Cardiology, and Interventional Cardiology. He is currently a provider at the Heart Center at Salina Regional Health Center. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much for coming back and joining us, Dr. Battin. Let's go ahead and get started with some questions while we wait for those phone calls to come in. First of all, let's talk about what's new and innovative in cardiology right now.
So I think the new and innovative space is still dominated in the structural space, and that would be interventions that we continue to make easier and more available for patients, particularly in the valve space. It's been largely a space occupied by major operations with cardiothoracic surgeons and surgical teams, and that has moved to a more percutaneous space, meaning we're able to insert valves or repair valves in the aortic, mitral, and even tricuspid positions with new therapies by way of access from the groin.
Okay. Now, you know, we were talking a couple weeks ago or last week about like colonoscopies and that everybody should go get one at a certain age. What about, you know, seeing your cardiologist, even if you think you're healthy, and is it a good idea to go check it out with a cardiologist?
I mean, I think more importantly is just establishing routine care with your primary care physician and determining if it needs to be escalated from there. You know, obviously anytime someone is uncomfortable or has questions, particularly if they have a family history, and by family history I mean, you know, a first-degree relative with premature heart disease, a mother, father in their 50s with a heart attack, stroke, something like that, then yeah, that probably should be escalated to a subspecialty care cardiologist. But just establishing routine care with your primary care physician, managing risk factors, these all contribute to heart disease, you know, high blood pressure, high cholesterol, smoking, etc., diabetes. Getting on top of that early will prevent problems in the cardiovascular system long term.
Sure. Now, if you do have a family member with heart disease in their history, that doesn't necessarily mean that's going to happen to you, correct?
Yeah, absolutely. I mean, it's definitely something that you need to pay attention to and should, you know, alert you and your physician to look at those risk factors and address them early on. They may have, you know, familial hypercholesterolemia, for example, and their first-degree relative didn't know it, and you get checked at a young age, you're able to manage that more aggressively, and so that doesn't necessarily mean that you're going to succumb the same fate that a first-degree relative did if you're able to identify these things up front and address them more aggressively. You know, additionally, the first-degree relative may have smoked a lot or whatever. If you don't smoke, that's a big feather in your cap.
Interesting. Okay. Well, we are going to go to the phone lines. We've got Jamie on the line from Beloit. Hi, Jamie. Go ahead with your question for Dr. Battin tonight.
Hello, Dr. Battin. I have had a heart valve replacement plus an aortic. It's the aortic valve, and plus the root of the aortic. And I was just wondering how long the life of these are, and what can I expect in my future. I had this in 15.
Yeah, so if it was a surgical valve, which would usually be an incision down the sternum or a medium sternotomy, most of the time they're implanting a bioprosthetic valve or a valve that comes from the heart lining of a pig or a cow. And those have, they're pretty durable, but you can expect about 10 to 15 years, give or take. Some will fall on the short side of that, and some are going to fall on the longer side of that. But I think in general you can expect about 10 years from our bioprosthetic valves that are put in either surgically or through the groin. The transcatheter valves are about the same. Mechanical valves are a little bit more durable. Chances are you didn't have a mechanical valve, generally reserved for a much younger population, but you are committed to Coumadin lifetime.
Okay, now you often hear of people having open heart surgery. You'll hear triple bypass, quadruple bypass. What does that mean?
Yeah, so that just means the number of rerouting they had to do to get a new highway from point A to point B. Basically, that's what a bypass is you're taking an artery from the chest wall or veins from the legs, and you're rerouting the blood supply from the aorta past the narrowing or the blockage to a spot just beyond that area within a hopefully healthy portion of the artery that lies on the heart. So if they're saying a triple bypass, well, they rerouted the blood supply, in 3 areas.
Okay. And how has surgery improved over the years?
I think by and large, by being less invasive and using techniques to avoid prolonged bypass runs and the use of the robot, and just being less invasive, not opening the sternum and moving towards larger bore access in the leg or a neck artery or even an arm artery.
Okay. Let's talk about the symptoms of coronary artery disease.
Mm-hmm. Symptoms are pretty typical for most individuals, particularly if it's stable or more insidious. So you can anticipate a long period of exertional type problems where you're feeling a pressure or tightness across your chest. I'd say anything that feels weird from here to here that comes on with activity and gets better with rest. Now that would be more of a stable, more like I said, an insidious type thing that comes on over a longer period of time. It's predictable, and its onset is predictable, and its offset. Symptoms that are unstable is where you talk about, crushing discomfort or a pressure or weight-like sensation that comes on all of a sudden out of the blue. One minute you're good, the next minute you're not. Lasts for 15 to 20 minutes. There may be associated shortness of breath. You feel nauseated or sweaty. Any combination of those things.
Okay. Does inflammation play a role with that?
It does. I mean, a lot of the studies designed to look at, inflammation and how different meds can impact that, and is it a marker? Some of that pans out and some of that plays out, but we haven't really identified any specific therapies or medications at, say, said marker that would necessarily improve survival.
Sure. And what are the risk factors?
High blood pressure is mentioned as a major risk factor for heart disease. Just about any form of heart disease. Heart disease is a generalization of diseases that impact the heart. That could be the blood flow to the heart or the coronary arteries, also known as coronary atherosclerosis. High blood pressure is the biggest risk factor for that. Heart failure or heart muscle dysfunction, where the heart either doesn't have the ability to push the blood out or it doesn't have the ability to relax. High blood pressure can contribute to that. Diabetes. contributes to all forms of different types of heart disease. High cholesterol is mentioned. And then as we get, further down the rabbit hole there, people that are on dialysis or kidney disease, certainly sleep apnea and obesity play a role as well.
Sure. Now, if a person cleans up their diet, stops smoking, starts exercising, can heart disease be reversed?
It can be reversed to some extent, but I think more than be reversed, it can be managed better, right? It doesn't, you may achieve a level, okay, here's what I have, and we've done some things, and I feel better, and I'm doing everything I want to do. So how do we create a stalemate? And sometimes that's the best thing that we can do is create a stalemate, and that's good because the longevity, the trajectory is still very good for most individuals. But definitely our medications, particularly if identified early, does actually reverse some of the disease.
Sure. And you mentioned to Jamie, I believe you said Coumadin, she would be using that. Explain what that is.
Yeah, so that's a blood thinner, and she, in her case, I'm just, in general, we're not placing a lot of mechanical valves. They tend to be bioprosthetic, meaning that they're coming again from the lining of the heart of a pig or a cow, and that does not require long-term anticoagulation with a blood thinner. But the mechanical valve, the Coumadin, that's an anticoagulant. It's an old anticoagulant. It's acts on the vitamin K dependent blood proteins that are responsible for clotting the blood. So those blood proteins are very specific to our diet, and so diet really impacts the blood clotting ability on patients with Coumadin, specifically green leafy vegetables, and different medications can really interact with Coumadin as well.
Okay, at what point, if a person feels like they might be having a heart attack or a heart episode, what point do they need to get to the emergency room?
Yeah, I think anything that's abrupt in onset, that makes you feel uncomfortable, that makes you feel bad, it needs to be a trip to the emergency department. Sure,
and what can a person expect? They go into the emergency room, what's going to happen?
I think, hopefully if someone presents with chest discomfort, they're generally prioritized. And, EKG, placed on oxygen, and get asked all the same questions 100 times by 3 different people. Blood work is taken, chest x-ray, and a period of observation. If, the EKG done hopefully within the first 10 minutes of arrival is concerning for an acute heart attack, then, things are going to happen very quickly. They're going to move through the process very quickly. And, those individuals that are having a heart attack will then be, if at a facility such as Salina Regional where we have the capacity to do emergent heart caths and opening of heart arteries, that's what would be done. If you're at a facility in a smaller community where those facilities aren't available, then they would receive medications to thin the blood and to actually dissolve the clot and then be shipped to an institution where a heart cath and interventions can be performed.
Sure. And you mentioned blood work. What can you find about the heart through blood work?
We measure a protein, or we try to, we're looking for a protein specific to the heart when we do the blood work. And normally, that protein would not be present in the blood. If you're having a heart attack, that means that the blood supply to that portion of the heart has been stopped or impaired, and therefore there is heart damage, and that protein will leak into the bloodstream, and we would be able to detect it. So we check it at point 0, and then we check it, an hour or 2 hours later. And if there's a change in what we measure there, then that would strongly suggest that there was some heart injury.
We are going to go to the phone lines right now. We've got Matthew on the line from Walker. Hi, Matthew. Go ahead with your question for Dr. Battin.
Can kids have a heart attack?
Kids? Wow. So I would say it would be extremely unlikely for a child to have a heart attack. I have seen very young people have a heart attack, people in their 20s. I have seen have a heart attack, and It's always very sad when young people have heart attacks. Someone that is really young, if they have a problem with the heart, it's usually something electrical or something that they were born with that was undetected, and that's more of a rhythm disturbance. But I wouldn't worry about that.
Okay. Well, what can you suggest to Matthew to help him get a strong heart?
I think if you're a young, healthy kid and you're doing everything you want to do, and you go to your doctor and they haven't detected anything, abnormal on exam or in the history that would suggest there's a problem, or if there isn't any first-degree relatives that have had a problem, you're probably okay.
All right. Okay. Sounds good. Well, let's talk about how does a person know, we were talking about going to the emergency room, how do they know when you're maybe just having a panic attack compared to, because some of those symptoms can resemble a heart attack. So how do you know the difference?
I mean, you don't. And that's about as honest as I can be. I mean, I think when you're having, again, an abrupt onset of symptoms that are concerning and they involve anywhere from here to there, you got to get it checked out. And if it ends up being that, there is no blood test, there is no magic marker, there isn't any, external beam that we can do that says that's a panic attack. We just we go through our process, and we want to rule out life-threatening issues, and kind of triage on to the next. Someone having a panic attack, that would be what we call a diagnosis of exclusion. When you rule out all the other things, you say, okay, maybe it was a panic attack. But stress, it plays havoc on the body, and stress is very real, and stress has physical manifestations, and we don't downplay that at all. And I certainly don't want to downplay that at all, because you can have real physical manifestations from stress and mental illness. So that's it, and in no way downplays any of that. It's very real. It's just extremely difficult to say that's what it is, but you have to go through all the other issues as well. Make sure it isn't something at the point life-threatening.
Sure. And can stress increase the risk of heart disease?
Yeah, no question. It can. I mean, there's a very specific phenomenon. There's a stress-induced cardiomyopathy or a Takotsubo cardiomyopathy that creates, transient heart failure that can be extremely debilitating, and make patients extremely sick early on. The good news is, with early recognition and treatment, you can recover from it fully. But that its name is stress-induced cardiomyopathy. So we see that not infrequently, actually.
What is a widowmaker heart attack?
Yeah, I mean, it generally represents a heart attack in a specific part of the blood supply to the heart, generally the left main or proximal left anterior descending. That traditionally has been reserved for the widowmaker, but I mean, any of that, it doesn't matter. Circumflex, right coronary, any major epicardial vessel supplying the heart can kill you if you're not treated early, but that's what that's where that comes from.
Yeah, and how many do you find, survive that?
I mean, it depends. I think with the early recognition and management, people do very, very well. This process is continually in evolution, and we continually have an ongoing performance improvement group of individuals at Salina Regional, a team of nurses and cath lab managers and physicians, and other cardiologists that participate in the chest pain meetings and chest pain accreditation, and making sure that we're doing everything that we need to do to continually improve our process and provide good care. But I'd say, when patients come and present in a timely manner, they're leaving the hospital.
Mm-hmm. Sure. And can a patient with a history of migraines be a candidate for heart disease?
I mean, I think anybody can be a candidate for heart disease, not necessarily specifically migraines, but there was some discussion about PFOs and migraines. I don't know that any of that ever played out, honestly, but certainly if there's underlying other vascular signs as well, you can have heart disease.
Sure. You often hear, I guess in the older generation, that a person has congestive heart failure. Mm-hmm. What is that?
Congestive heart failure is, it's heart muscle dysfunction, and I think the best way to, two types of that would be the inability to pump out the blood that the rest of the body is calling for, or an inability to relax, and therefore the heart is much stiffer, or any combination in between. And the two are managed a little bit differently. The most common would be that we see, I think, would be heart muscle dysfunction, where the heart is not pumping the blood adequately to the rest of the tissues, and the one where the heart muscle doesn't relax, that's a little bit tougher to manage, and more patients kind of fall into that bucket. And whether or not their problems are truly related to a stiffened heart, I think there's definitely some debate out there, certainly within our field, that there might be a lot of other risk factors, a lot of other disease states, particularly kidneys and veins and weight, for example, or sleep apnea, can create a lot of similar problems that would mimic that.
Sure. And who might be a candidate for a pacemaker?
Yeah, candidates for pacemaker, any individual that has unexplained passing out spells or fainting spells, usually over the age of 60, where we find an abnormality in the conduction tissue. So either on an EKG or some monitor, either a 24-hour or 30-day, or even monitors that we place under the skin that monitor the heart rate and rhythm over a longer period of time, sometimes up to 4 to 5 years. If we find evidence that the heart quit beating for 5 to 10 seconds, or if the top chambers and the bottom chambers are not communicating adequately by way of this integrated circuitry that should be in the heart, then they may be a candidate for a pacemaker.
And who might be a candidate for an aortic valve replacement?
Those are individuals that have either a degenerative aortic valve. The valve ages as we do. It gets scarred, it gets calcified, it becomes more like bone, and instead of opening and closing as a nice thin piece of tissue should, its ability to open and close gets less and less. And once it becomes so narrow that it's creating symptoms, shortness of breath with activity, exertional type fatigue, I'm exhausted, etc. Those individuals may be a candidate for aortic valve replacement. Individuals that are younger usually are born with a valve that has maybe 2 cusps instead of 3, or 2 cusps that are underdeveloped and fused together, making it functionally a 2-cusp valve. They tend to wear out a little bit earlier, usually in their 60s. But also get scarred down and calcified and don't open and close as they should, and will create a similar type of symptoms.
Okay. We have just a very little bit of time, but we're going to try to squeak in one more caller. This is Mary on the line from Salina. Hi, Mary. Go ahead with your question for Dr. Battin.
Yes, I was wondering, I was diagnosed with congestive heart failure, and I was curious. Somebody told me that I should not sleep on my left side, that I should sleep only on my right side. Does it make any difference which side of the bed, which side you sleep on?
No. No, short answer. So we managed to get that really quick for you. It doesn't. I think so. Patients with congestive heart failure, if you don't have the ability to lie flat, if you get a little bit short of air or you feel like you're suffocating, then elevating the head of your bed or getting a pillow or two where you get your head just above your heart a little bit will help with those symptoms. But generally we want to sleep on our left or right side, because even if you don't have sleep apnea, if we sleep on our back, we tend to obstruct our airway more. And we snore, and that's not necessarily good. So I think really it comes down, if you feel fine, you can sleep on your left side, sleep on your left side.
Great advice. Thank you so much for Dr. David Battin from Salina for joining us tonight on Doctors on Call. On our next show, we'll be discussing physical therapy. You can email us questions for our next program. That address is doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Salina Regional Hospital. Experts, neighbors, friends.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.